Our rate of SSRI, which is an antidepressant use, doubles through the perimenopause transition. So Kelly Casperson and some of the menopause are fighting to have the black box warning removed from vaginal estrogen. Vaginal estrogen has no contraindications. If you have a vagina, you can use it. Stop suffering, stop relying on just lubricants. You need vaginal estrogen stat. Interstitial cystitis, for the majority of patients, is misdiagnosed when it really is genital urinary syndrome of menopause. If you're not being offered vaginal estrogen, that should be malpractice. Women who are diagnosed with breast cancer on HRT have lower stage and higher survival rates than women not on HRT. We have got to stop doing this to women. Automatically assuming that her psychology is somehow involved in her hot flashes. Senile vagina.
Senile vagina, she said it, and she said so much more in this roundtable discussion that I'm about to share with you. Last month, I had the honor and privilege of spending some time in Austin, Texas with a group of creators at a creator house. And one of the highlights of my trip was that I was privileged to invite Dr. Mary Claire Haver to drive up from where she lives and works in Texas and join us at the Creator House for a roundtable discussion with some of your favorite creators. Now, if you're not familiar with Dr. Mary Claire Haver, she is a board certified OBGYN. She is a menopause specialist. She is an author. She just published her second book, which is called The New Menopause, and it is absolutely fantastic. It is a must read. It is, as I last checked, a New York Times #1 bestseller. We are strong in our voice, and it is time for us to carry on this conversation, because this half of our life is going to be the best half of our life. We just have to have the right information. And I feel like Dr. Haver is one of the pioneers who is making sure that message is hammered home, that we need the right information so that we can make informed choices. Now, I am going to share down in the description box my own personal menopause toolkit. This includes everything that I have learned in the last year and a half and what I'm kind of implementing into my own life. Supplements that I'm taking, the practices that I'm doing to ensure the best health that I can, the things that I think are the most important for longevity, how I'm managing my sleep, what I'm doing for HRT. Honestly, some of it might end up being a little bit TMI, but I am sharing all of it in that menopause toolkit. I hope you'll check that out. I hope you enjoy this video, and I do hope you'll give Dr. Haver some love in the comments. I'm gonna link her everywhere. All right, I'm gonna roll this, and I will see you on the other side. Okay, I'm going to read a passage from your book, and I really would love to ask you about it. You say that at age 48 that you and your healthcare provider decided to stop taking the pill to see where you were hormonally.
Right.
And around that same time, your brother Bob got ill, and unfortunately he passed away, and you started to have symptoms, and then you said you tried to power through it. Mm-hmm. So you decided to take hormones, and what I wanted to know was, how is it that an OBGYN felt that she had to power through it, and now here you are, this world-changing, amazing women's advocate, menopause expert. How did that happen?
So, that was 2015 when I stopped birth control pills right at the same time he got super sick and then succumbed to his illness. And at the time, based on what I had been taught in medical school, which was pretty much nothing, and in residency and all of the fallout from the Women's Health Initiative, I was kind of under the impression that you only give hormone therapy if nothing else is working for the shortest amount of time, for the lowest dose possible. Otherwise, you were going to cause harm to the patient. So here I am, miserable, suffering miserably. And I kind of treated it like I treated my epidural in labor, where I was like, well, let me just see how it goes, and I'll see if I can tough it out. Mm-hmm. And of course, I got an epidural at 3 centimeters because that was not happening. It was not going to happen without one. And I look back on that time, and I really felt like I was throwing in the towel. I was a little bit of a failure because I wasn't strong enough to tough it out. And since that time, everything that I've learned about the benefits of hormone replacement therapy, it's more than just hot flashes, that it's actually protecting my brain and my cardiovascular system and my bones and my general urinary system and all the other organs in my body. So it did take years of self-reflection, research, meeting other menopause providers, real experts in this space, to realize that for me, thank goodness that I was able to start at a time where I could reap the most long-term benefits, and I didn't hold out for longer, which would have actually harmed me in the long run.
But can we just take a step back for a sec, and can we just go over a little history of how we got here? Because I was looking at the history of HRT and menopause the other day, and HRT at one point, Prempro, was the most prescribed medication or the most used medication in the United States in the early 90s.
Yeah.
And then we got to the point where there was the flush heard around the world, and now here we are today where we're trying to get people back to just a normal place where you could have a conversation about it and find out what you need. So what happened in those years?
Hormone therapy kind of was developed in the 20s and 30s, and they were like boiling animal ovaries and turning it into serums. Yeah, it was really kind of archaic, but it was a way to get hormones. So then Premarin was developed, and Prempro came out because if we add a progestin to the estrogen for a patient with a uterus, then it's going to protect the lining of that uterus from developing endometrial cancer. So you're right. In the late 90s, about 38 to 40% of women were on some form of hormone replacement therapy in their menopause journey, and most of that was Premarin or Prempro. Premarin if you had a hysterectomy or didn't have a uterus, and then Prempro for everyone else. So when the Women's Health Initiative, here we go. It's the first major study done for women's health in menopause. It was a $1 billion study. It was from the National Institutes of Health. This was incredible. Like, we were so excited when I was a resident to learn that finally women were going to be studied. Aging women were finally getting their due. And so they developed this study to see, we knew from observational studies that women who were on HRT had lower cardiovascular disease. So the question was, is that just because healthy women get HRT or wealthy women get HRT? And is that an artifact of patient selection, or is this a real benefit? So in order to do that, you need a randomized controlled study. So they recruit tens of thousands of women in each arm. The outcome was cardiovascular disease. Is this protective or not? So they started with an older population because we don't get heart disease until we're in our 60s and 70s. So the average age of the WHI study was 63. Remember, the average age when we start menopause hormone therapy at the time was 50, 51. So we're already 10 years into the mix. They excluded women who had hot flashes.
Wait.
Yeah.
But wait.
Because they would be able to tell who was on placebo or not. Remember, this was a randomized double-blind trial.
Well, okay,
So
that
what
makes
women will
sense.
know immediately if our hot flashes start. So we've already excluded 80% of menopausal women if you had severe hot flashes. If you had some kind of a hot flash that would require treatment. So like lots of nuances people don't understand. So we're older, we're doing a very small subset of women who don't have hot flashes so that they wouldn't be unblinded, and that they're like, my hot flashes went away with this magical pill. Did I get placebo or not? So that's why that happened. So they put everyone on the meds, half on placebo, half not, divided them with, people with the uterus got Prempro or placebo versus Premarin or placebo, and they start measuring. What they found was that there was a very slight increased risk of breast cancer in the patients who were on Prempro, but not on the patients on Premarin only, on estrogen only. And so they immediately stopped that arm of the studies. And then the headline, here's the problem. They stop the study, they call a press conference at the Watergate Hotel. They don't publish the study yet. It's not available for us to read. They just hold this national press conference. Every major news outlet was there and said, estrogen causes breast cancer. 80% of women immediately stopped their hormone therapy, threw them in the toilet, threw them in the trash, and there were almost no new prescriptions of hormone therapy starting. Then they kept the estrogen-only arm going because they actually had a decreased risk of breast cancer. We'll talk about what that risk really meant. But then they found a slight increased risk of stroke. Again, biological explanations for all of this. So let's go back to the Prempro arm. So it wasn't the estrogen, because the estrogen-only arm had a 30% decreased relative risk of breast cancer. So it went from, I hope I get the math right, about 4 out of 1,000 women per year develop breast cancer on placebo. We get breast cancer because we have active breasts, right? To 5 out of 1,000. That is a 20-25% increase relative risk. The absolute risk was about 1%, 0.8%. So there's a big difference when we're talking about statistical populations versus PENN. What is your risk of breast cancer if you take this versus you don't take it?
Right.
And women weren't given the agency to say, I'll take that risk because I might have decreased risk of cardiovascular disease.
Right.
What they did not show in the older population was that cardiovascular disease risk was improved. It was neutral. Now, in the 22 years since that all got published and the risks were dramatically overestimated and the benefits were never discussed, decreased risk of colon cancer, decreased risk of osteoporotic fracture, all the things we knew already, decreased risk of genital urinary syndrome, decreased risk of UTIs and urosepsis and hospitalizations in elderly patients. You know, like
The list goes on.
it's like for the next 20 years, the only conversations around women's health were centered around the risk of breast cancer. No discussion of cardiovascular disease, osteoporosis. Those are just old lady diseases and you're going to get them. There's nothing you can do. And no one talked about relative versus absolute risk. And that's a difficult, for me, even as a physician, sometimes that's hard for me to wrap my head around. Not giving patient informed consent and allowing her to make a judgment for herself. So then it kind of like throw out the baby with the bathwater. Anyone with a family history of breast cancer can't take estrogen because it might kill you. Anyone with a history of a blood clot or a stroke can't take, or a family history. And so all of a sudden, people are terrified of hormone therapy. I was a little bit scared of hormone therapy, like going back to my story. I was like, well, I can't live like this. So if I get breast cancer, I get it. And then, you know, and I remember like me reading Estrogen Matters from, you know, Dr. Blooming and Dr. Tavris and being like, wait. Why hasn't the American Board of OBGYN brought this to the forefront? Why, when I read my recertification articles every year, no one is talking about this? And when you dig into the history of women's health and the patriarchy and misogyny, I mean, I hate to go there, but it's there. It's like, why is it that when you look at funding for women's health, the overwhelming majority of the research dollars go into reproduction? Getting you pregnant, keeping you pregnant, having a healthy pregnancy. Important stuff. It's like 10 to 1, the spending. Why is the last third of my life
Not important.
not as important to study, to keep me healthy? Yes, we're living longer than our male counterparts, but we're living in 20% poorer health than our male counterparts. So women are twice as likely than their male age matched counterparts to end up in long-term nursing care facility for fragility. For dementia, and our lack of hormones has a lot to do with that.
So you touched on why, but why do you think they did that? Why did they do that press conference? Why did they not say your risk goes from 4 in 1,000 to 5 in 1,000, which is a lot
still alive.
different
Ask
than your
them.
25%? I mean, because the difference between saying 4 in 1,000 and 5 in 1,000 and 25% increased risk is huge to anybody. And they knew it was 4 to 5 in 1,000.
I think it's politics. I think it is a certain mindset of keeping a person in their place, a certain mindset of I've spent all these years researching and studying this, and if I change my view, I might lose credibility amongst my, you know, there's a lot of like academic politics involved here, and some of those researchers to this day are digging their own graves on this data. And even the Lancet just published this 4 articles, and so like the menopause got together and, you know, we've done massive rebuttals, and, you know, at the end of the day, there's still people who are writing articles as experts in this field who feel like a female should accept her due and she can just outthink her menopause and everything will be fine.
The authors of that Lancet article are a couple of women, aren't they?
All of them were women.
I mean, that's even...
I know.
That's even more incredible.
One of the lead authors was one of the lead researcher on the WHI. And so when the New York Times article came out about menopause and heavily was, you know, going after the WHI data, I think they felt like they needed their pound of flesh. I literally am speculating. I really don't know these people from Adam. But when you look at the Lancet data and who the articles were, they quoted their own studies in 20% of the articles. And they only used 200 articles. And 40 of them were their own data. And they all have vested financial interest in keeping these thought processes going. And CBT, cognitive behavioral therapy, which has its place.
100%.
But that is assigning a psychological reason to a biological issue, and we have got to stop doing this to women. Automatically assuming that her psychology is somehow involved and her hot flashes.
Yeah.
Let's talk about the good stuff that's come out of that study.
let's talk about
Because
the good
there's some amazing data that's come out. They continue to study these, even though they stopped the medication, they continue to gather information on these patients for years and years and years. And what they found is the American Heart Association, the AHA, and Circulation Magazine, they went through and fine-tooth combed the data, the raw data, and subdivided it by age. And what they found, we have now what is the healthy cell hypothesis and the timing hypothesis. So the healthy cell hypothesis basically says that estrogen supports a healthy cell, and it is better at prevention than cure. When we lose our estrogen is when we accelerate aging of our cells.
Wow.
And the timing hypothesis is that the timing of when you start hormone therapy in relation to your menopause matters. So the women who started hormone therapy within the first 10 years of their menopause or before age 60, because the average age is 50, 51, 52 in some studies. So you've got this 10-year window. If your cardiovascular disease has started and you have plaques and calcified plaques, we might make that worse, at least in the first year of starting hormone replacement therapy. But if you get it in that 10-year window, it's protective. So we are protecting the endothelial, which is the lining of the cells that line our blood vessels in those carotid arteries, in the cardiovascular arteries around the heart. And so we can provide you in protection if you start early and continue that therapy. Where the gray area is it okay if you've been menopausal for 10 years? And now, is it okay for you to start hormone therapy? Maybe. So it's a more nuanced discussion, and we need to check, do you have any plaques? So we can do calcium cardiac scores. It's a CT scan of your heart. You can do an ultrasound to measure the thickness of the intima of the carotid arteries, that lining, those cells that line, to see if you've already have some plaque buildup. So those are the things I do for my patients before I say, okay, no, absolutely not. Because if she's healthy, we could prolong her health for longer with hormone therapy. And that data came from the WHI when they looked at age. And so the other thing is, like, when I talk about protein and frailty, you look at that and you say, okay, the women who ate more protein had lower fragility scores just based on protein intake. And that all came from the WHI. So there's a lot of good data that came from this.
So you've got these tests that you'll do if somebody is past that 10-year window. If somebody is just entering menopause, are there tests they have to do?
The menopause, we don't do a lot of hormone testing. Perimenopause is a zone of hormonal chaos, and if you're in it, I hear you, girl. And so you cannot use a one-time blood, urine, or saliva test, even a 3-day blood, urine, saliva test. Let's do some endocrinology so that you guys, followers, understand this. We're born with all of our eggs. When we're inside of our mom's tummies, we have the most eggs we'll ever have, 4 to 5 million. By the time we're born, we're down to 1 to 2 million. Because they are constantly deteriorating over time. By the time we're 30, we're down to average of 10%, so about 120,000. And by the time we're 40, we're down to 3% of our egg supply. So every month when we're in normal, healthy reproductive cycles, we have this kind of EKG looking estrogen surges, then our progesterone surges, all driven by hormones from the brain. So the hypothalamus in our brain is constantly sensing for estrogen our whole lives, whether we're menopausal or not. And when the estrogen levels are low, it sends a signal to the pituitary saying, make more. The pituitary goes, all right, ovary, you're up, let's go. And starts doing LH and FSH pulses to the ovary. The ovary's like, I got you, coach, all right. Starts recruiting these little germ cells to try to ovulate, and that's where the estrogen and progesterone production comes from. Well, we develop resistance, like insulin resistance. We develop LH and FSH resistance because the ovaries are aging twice as fast as any other organ in the female body, and it can't do the same thing. So the brain's like, hey, I'm not seeing my usual estrogen surge. Pituitary, what's going on? He's like, all right, I'll just send more hormone stimulation down. And so you end up with these giant surges, and then the ovary just explodes an egg all of a sudden, a little bit late sometimes, much higher estrogen levels. Then we get these deeper falls, and then the progesterone takes forever to catch up. And so instead of this nice EKG, you end up with these chaotic cycles that are no longer predictable. And all the ensuing, besides what's happening with our periods, every other organ system in our body gets hit.
I was going to say, the evidence of it is that your periods go crazy.
Yeah, so that's one of the easiest recognizable causes. But anxiety, depression, frozen shoulder,
Sleep.
disruption, what's happening here.
Can we just circle back to the hormones? So we were talking about perimenopause and how do you know that you're in it? But let's say that you don't have periods, you're super skinny or whatever, or you have an IUD and you don't have periods. How do you know, what's going on? Because I think the periods are a big indicator. And like you said, you got to listen to your body.
Or an ablation or something like that.
Right. So you don't have periods for whatever medical reason, or how if you don't have that period to hang on to. So for those patients, they're the ones I'm going to get some hormones on to see are they postmenopausal? Are they done? We're really good with a one-time blood test to diagnose postmenopause, but perimenopause it's not super diagnostic. So there's something called the green score, the green scale. It was developed in 2008. No one actually uses it, but it has been validated to be able to define if the constellation of symptoms that you're having might be related to perimenopause. So when those patients come in, I'm doing a ton of blood work, just not hormones. I'm checking inflammation markers, the CBC, all their basic blood tests, but I'm adding in, do they have like their high sensitivity C-reactive protein? We're checking iron levels. I'm getting a vitamin D. I want to make sure I'm not missing something that these deficiencies could be also look a lot like perimenopause.
Right. Yeah. We just wanted to define like what is menopause for the people who don't know that it's, is it an event? Is it a...
Going back, menopause medically is defined the worst possible way, 1 year without a period. And what if you don't have periods?
Right.
You don't get a definition. What it represents is that you have run out of eggs. Like we talked about at 40, you're down to 3%. At your menopause, you are down to no eggs.
No eggs.
No functional eggs. You might have 1,000 left.
So it is an actual thing. It isn't just a woo-woo time when you're like, oh, it's menopause. It is literally.
Yeah, and every day after that point, you are postmenopausal until you die. So we should not define menopause by the presence or absence of symptoms for a postmenopausal patient, because your genital urinary system will 100% be affected every day of your life after menopause. Your bones, your muscles, your musculoskeletal system will be affected. And so it is so important to realize like you have to protect those systems or they're not going to protect you as you age.
I think something big about that too is there are so many people that say, I don't have any symptoms, I'm fine, I went through this. And yet it's all of those silent things that are happening to us as we age due to lack of or no estrogen that is detrimental to our health and to the vitality of our life into old age. And we may have never had a hot flash or anything, and that does not matter.
For those patients who come in and they're like, look, just set me up for success. I'm like, tell me about your grandmas. Were they in a nursing home? Did they fall and break? Were they 95? I know she probably had some extraordinary health care, but Queen Elizabeth met with the Prime Minister, felt a little tired, went to bed and died. Completely, very, very functional until she wasn't. My mom's mom ended up demented in a bed for 5 years, completely non-functional, but alive. And then my mother now has been on a walker for 10 years and is now in the end stages of dementia. And I'm like, I don't want that.
Yeah.
So what are the things that I can do? Now, HRT can be a really important tool in that toolkit of avoiding those type of things.
Talking about like perimenopause, I was the person that I thought, okay, menopause is hot flashes. And it's no periods. And so I did have frozen shoulder in both my arms, over a period of a few years. And I was blaming it on myself. I was like, I'm working out wrong. I'm doing this wrong. And then it was recently that I learned that is such a significant sign. What are like other common symptoms that people might just like balk at and think it's something else?
So the ones that when I talk about that blow up the internet are ringing in the ears, so tinnitus. Whenever I talk about that and the connection to menopause, people go crazy. The other palpitations. Palpitations are a form of vasomotor symptoms. So palpitations are a form of a hot flash. And that people, they're like, wait, what? Wait, I had $1 million cardiac workup. Wait, I wore a Holter monitor for a month. I'm like, well, not to say you didn't deserve a cardiologist to peek in on things, but you probably could have just started a little HRT and see if they got better. That is how common they are. So musculoskeletal syndrome of menopause, including frozen shoulder. Joint pain with no injury.
Yeah.
80% of women will have it, and for 20% of us, it is your worst, most debilitating symptom. For some, debilitating.
So speaking of the symptoms, I'm going to have to plug your new book because there is a whole entire section in here called the Menopause Toolkit, and I marked it off because it is literally like this much. I have the paper copy, but
It's like a third of the book.
it
Yeah.
is a huge, and all of these symptoms, I would love to hear you just tell us about the Menopause Toolkit. That is such a valuable resource for women to have that, and I'd love for you to explain what it is.
So when my patients come to me and are like, we're trying to map out, their best life for the next 30 years. And first thing we attack is their symptoms, like the acute problems. And then we're going to talk about how to protect your health long term. But what I've learned through this whole menopause journey and research and my friends and the menopause is that every organ system in our body is affected by the loss of estrogen and progesterone and testosterone. And that may look like, I counted 75, 76 different symptoms throughout each organ system. So I wanted to address each of those individually. I tore through the literature to see what we know and what we know hormones help with, what other pharmacology might be available, what lifestyle changes might be affected. Because this is the thing that most women are walking to their doctor's office and they're like, oh, I don't know what it is, just part of your life,
Part of getting old.
Yeah, and so I just wanted a toolkit for people to use. Now, some of them are robust and you have multiple things that you can do, but some we're just now learning about the association with estrogen loss and we need more research.
Can I jump in here on something
Yeah.
about that? Some people are probably wondering like why a guy isn't here talking anyway.
I think it's so important.
And it's it's not just about hair. That's obviously my background. But as a husband to this lady over here who has self-prescribed herself going through this change and this challenge right now, there's a lot of symptoms that happen clearly. So as a guy, what do I need to know? Like, how do I best support her going through these things? Because I don't even know what the symptoms are. All of a sudden, she's in the middle of it, and we don't know. So what should I be looking for, and how can I best support her to get her through it?
So just like where I sit on this side of the desk, validate. Absolutely. Like, I hear you, I see you, it's not her fault. Right. Imagine, if at 50, at the average age of 51, if all male testicles just shriveled up and stopped working, if you ran out of your spermatozoa factory and that was it, and you had no more testosterone production, that was clinically relevant.
And it caused a bunch of other things, like it hurt to have sex.
It would.
And
it would.
You would
Your
every time
mental
you
health would
sneezed.
change. Your muscle mass would dramatically decrease. That's what's happening to her. It doesn't have to be that way. And so getting your head wrapped around it is the first step of all of these things could happen. And like, all right, let's figure this out together. How are we going to, just being there, validating her, if she woke up tomorrow with whatever medical diagnosis, I know you would be there for her. When we look at the mental health picture, our rate of SSRI, which is an antidepressant use, doubles through the perimenopause transition. Yeah, it goes from 10 to 20%. 1 in 5 women is on an antidepressant at the age of 40, and then it goes up to 25% after the age of 60. Your most likely time to commit suicide for a female is 45 to 55. And so all probably to do with, now, if she was able to walk into a doctor's office confidently and say, I'm having all these symptoms, or to her loved one and say, I'm not sure what's going on with me, and you could say, this might be your perimenopause. Let's go get some help.
I don't think I said that.
Let's figure this out together. How much better would it be for her mental health if immediately it was validated? And that's not your fault. Society hasn't caught up with this yet and the realization.
So, Dr. Haver, I polled my audience beforehand because I knew you were coming. So I said, ladies, this is your chance to ask Dr. Haver all your questions. And the number one question that they ask, because my audience is a little older, they're mainly postmenopausal. So a lot of them are 61, 63, 68, 75. They all had the same question. You already touched on this a little bit, but they want to know if it is too late for them and they can't take HRT at this point, what are there other lifestyle things that they can do to help themselves?
Absolutely.
And also, is it 100% too late? Like, has the door closed, or is it never really 100% too late?
Let's break that down.
Yeah.
If you start hormone therapy in the most therapeutic window within those 10 years, there's no age at which you must stop. It's different than starting older.
And if you go in and your doctor agrees to give you HRT and they say, I'm going to put you on the lowest dose for the shortest amount of time.
So that is
Do you
no
push
longer
back on
a
that?
thing. You absolutely push back on that. You ask them why and to supply the data. The latest recommendations from the Menopause Society are It is the dose at which symptoms are controlled, whatever that dose is, for as long as it will keep you healthy.
Right.
And that is a conversation I have every year when my patients come back. Have you developed any new medical problems? Have you developed a contraindication? If not, let's continue. I might die with an estradiol patch on.
I'm hoping to. And I feel like I almost missed the window of opportunity because all this information wasn't coming out when I was first going through, menopause that first year without a period. It took me 4 years and 3 doctors to get on the right HRT with the right delivery method.
When they looked at that in the UK, it was 6 doctors on average.
Oh, gosh.
6.
Yeah.
Before anybody had a clue that all these things that she was suffering were her menopause.
In the UK, they have androgen, and which I know is out of Australia. Why don't we have that?
Ask the Food and Drug Administration. So Kelly Casperson and some of the menopause are fighting to have the black box warning removed from vaginal estrogen.
Yeah.
And so all the estrogen we're talking about here is systemic estrogen. That's treating your brains, your bones, everything, right? Vaginal estrogen is treating the vagina, the bladder, the vulva. It's local. And so the local therapy is not systemically absorbed, and it's been tested multiple times in any clinical situation. So vaginal estrogen has no contraindications. If you have a vagina, you can use it, regardless of what's going on in your body elsewhere.
Right.
And so you have blood clots, you have breast cancer, you absolutely can use vaginal estrogen. So I want to be clear about that.
And what symptoms would that help with?
So let's go through history. In the 50s and 60s, they called it senile vagina.
Oh gosh.
Wow. What?
How does
Senile
vagina?
vagina. Senile
Right.
vagina, yeah.
Okay.
When we lose estrogen, the tissues of our bladder, the bladder neck, the urethra, which is the tube that drains our bladder out to the world, and the vulva, like everything from like the hip bones down is highly estrogenized. And when we lose our estrogen, those tissues become way less resilient. So we lose elasticity, we lose mucus production, we lose thickness, we lose resilience to infection. It's just awful. So the number one treatment that works for recurrent UTIs in a menopausal patient is vaginal estrogen, not recurrent antibiotics.
Wow.
And if you're not being offered vaginal estrogen, that should be malpractice, because we can decrease the rate of hospital admissions for urosepsis and UTIs by 50% if all women just use vaginal estrogen prophylactically after menopause. So if you're having uncomfortable intercourse, and when you didn't before, and this is new, stop suffering, stop relying on just lubricants. You need vaginal estrogen stat. So
just
we
do.
think that interstitial cystitis for the majority of patients is misdiagnosed when it really is genital urinary syndrome of menopause. We also think that most fibromyalgia is misdiagnosed, and it really is musculoskeletal syndrome.
Okay, so since you talked about how that is localized, I know we've talked about this before, but can you explain to people why they can use an estrogen-based face cream, they can use vaginal estrogen,
Okay.
and that is not systemic?
So why? We lose 30% of our collagen in our
Yeah.
skin. We lose the transepidermal water barrier. We have massive changes in our skin through the menopause transition.
Yeah.
And 30% loss of collagen in the first 5 years of
Right.
menopause. We can slow that down with estrogen. So topical has been shown to help both with collagen and with elastin, where systemic so far has only been shown to help with collagen. Another thing, talking about sexual health, is that we see, and a lot of people don't talk about it, but we see delayed orgasms and less intensity or just loss. And we're thinking that the vaginal estrogen can go a long way to help with that as well. So.
Let's say we have an example of an older woman who's, say, 68, and she's in good health and she works out and everything, and she can't take estrogen for whatever. Or like, just
She doesn't want to.
She comes into your office. She doesn't want to. Or she's not a good candidate. What can she do to be the healthiest person if she's completely missed the window?
So I would have a discussion with testosterone with her and its benefits.
Okay.
We know that for sure it's going to help with desire. So if she has any issues with HSDD and medicine or decreased libido, and we've ruled out other causes, so she's not having pain, we're going to talk about that. I'm going to talk to her about vaginal estrogen because it's a whole different discussion because it can be preventative for UTIs and the health of the genital urinary system. I'm also going to do a deep dive nutrition, movement, talk to her about osteoporosis prevention. We're going to get a bone density. I'm going to do her body scan, look at her visceral fat, and we're going to have very focused conversations around her body composition.
Okay. And then is it going to be more lifestyle changes? Are there other medications that can help? Like, if you can't take estrogen, but you are osteopenic.
Yes. The reason why we have osteoporosis is we are constantly remodeling our bones. This is healthy. That's why a broken bone will heal. You don't have the same bones you had 10 years ago, 5 years ago, because we're always chewing up bone and laying down new bone. And the resorption, the chewing up part, gets a little faster, and the laying down part gets a little slower when we lose estrogen and the sex hormones change. So the aging process is part of it, but menopause accelerates it. And so the medications outside of estrogen, which is the most effective preventative thing that we can do, is stay on HRT for our bones, are the ones that decrease resorption.
Are there any like more holistic or like supplementation or anything?
So when you look at the studies for bone loss, they basically take people with osteoporosis and see what makes that better, because we can measure those bone densities. One, I think every woman should just pay out of pocket at 45, 50 and go have a bone density done. Most women are not diagnosed with osteoporosis until they fracture. And they're not screening until 65, which in my opinion is way too late. Do not wait for your insurance to catch up with that. That is one investment you should make in yourself. Weight-bearing exercise, again, the musculoskeletal unit works together. Strong muscles equals strong bones. And so adequate protein intake, key. I start my patients at 1.5 and I go up from there for protein recommendations. Avoiding the simple sugars, making sure that you're doing at least 2 to 3 days a week of resistance training, progressive load, getting stronger and stronger.
What about other supplements? Because, your doctor will say, well, make sure you're taking enough vitamin D and calcium.
Okay.
And that's all you ever hear.
Neither vitamin D supplementation nor calcium supplements have been shown to improve bone density. However, people who are deficient in these two have weaker bones and weaker muscles.
All right.
So calcium in its natural form in food is way better option for you. And if you absolutely can't, then we'll supplement only that little tiny bit, because what they found was that calcium supplements lead to kidney stones and they lead to increasing rates of plaque calcification.
So you just made me think of something. On your cruise, we did the Pause Life retreat, which was wonderful. I understand you're going to do it again, which is when you launched your collagen supplement that she was just very casually talking about, skin and bone, and I take it is wonderful. I would love for you to talk a little bit about the Pause Life retreat and just tell us a little bit more about your collagen.
So over a year ago, when the beauty influencers, the babies, were going on all these trips to Dubai and all these, fabulous influencer trips, my followers were like, hey, where's the menopause trip, So I was like, that would be fun. Let's do a menopause trip. So it was kind of a tongue-in-cheek, and then it kind of turned into, let's do a menopause retreat. Let's bring all these people together and have these great discussions about the future of menopause care and what you can do if you have X condition or Y condition. And so I gathered up the menopause, a few members, and was like, hey, y'all want to come on a cruise out of Galveston? Sure. And then we opened it up to the public. We had 100 spots. We filled almost immediately. And it was one of the most life-changing experiences, you got to go, of my life. And so the minute it was over, we're literally walking off the ship. I'm dragging the luggage and everything. And I'm like, we got to do this again. But no more cruises. We had seasickness. There was a rogue wave that took out a few cabins. It was the venue, nothing to do with the cruise, wasn't the right venue for everyone. I'm like, we should just do this on land. So we are going to host the next menopause retreat, bigger and better. This is the information, because all of those people become disciples. And they learn the science and the message, and then they spread it out to their...
we were talking about this yesterday, and I said, you came off the cruise and you felt like you just wanted to spread the word. And that's awesome.
That was the impetus for doing the next one and
when
making
you're empowered,
it bigger.
you want to share that, right? Because you're just like, you feel so alone in like this transition, and you're like, what is going on? But you keep it to yourself, right? But then when you share, oh my gosh, I've been feeling like this, and then people are like, oh, me too. Me too. Oh my gosh. And then you don't feel so alone.
That's the beauty of social media. Had I had an easy menopause, or had I not been, on social kind of finding my footing, I don't know if I'd be where I am today. If I just would have breezed through it and, gotten off the pill and been like, I don't know what's going on. I just don't have periods. And, that I wouldn't have been able to build this platform
Yeah.
and share everything and learn and have the desire to do it. And so I'm just so grateful. For
Yes.
And for those women who like are older, they may have missed it or they may not, but they would need to have a discussion with a good doctor and there are no resources in their area. Where can they find?
So menopause.org has a certification program,
Okay.
the Menopause Society. Look for the certified check, not just
Okay.
all the, they list all of their members, but like they need to be certified.
Okay.
It's not perfect. That's one place to start. I'm going to start teaching clinicians how to do menopause care the way I do it. So that's coming 2025, or actually by the end of this year, we'll have it. Also, there's some great telemedicine options
Yeah.
that are just built to take care of the menopausal patient and they have trained their providers. I've vetted 3 of them. They do not pay me to say any of this. I am friends with them, but so MIDI Health takes insurance. They're more traditional model. They give you a regular prescription you can take to the pharmacy. Alloy Health is another really good one, and then Evernow is another.
One of the things that I wanted to touch on is that I just upped my dose of estrogen. I switched my patch up because I wasn't really having a lot of relief of my symptoms. And I was afraid that, like everyone's afraid of breast cancer with HRT, that going up a dose would like increase that risk more. But I think what I've learned from you guys is that increasing your dosage does not increase your risk of anything.
There is dose-dependent risk of strokes in some patients who have predisposing, but usually in that first year of therapy is when we see the stroke happen. Blood clots, that is dose-dependent, but as long as you do a non-oral formulation, we don't have the venous blood clots, the ones that start in the legs, so you can do a transdermal option for that. So again, nuanced conversations. What they found is that in the patients over 65, and this was just published this week of this filming, they followed Medicare patients who happened to have been left on hormone therapy past the age of 65, and if they were on hormone therapy versus not, or if they had stopped it, the ones who stayed on it had lower everything. Every disease you can think of. You're just a little bit healthier with hormones than without. What they found though was they did better on the lower doses. So like we're all thinking eventually, like once the hot flash risk and all that declines, though 40% of women in their 60s will still have hot flashes, by the way.
Right.
Then you want to start tapering them down. You can keep them on it, but you want to go patch, it looks like, and then maybe taper down into their 70s and 80s.
So, Dr. Haver, a lot of my audience wants to know, if you've had breast cancer, what are your options?
It depends on your stage, your type, but you can very much not increase your risk of recurrence after treatment and be with hormone therapy. That is possible. So that is a very nuanced conversation, but women are being denied that conversation.
Right.
They're all told, no, you can never have estrogen. Da, da, da. Here's the thing. Estrogen doesn't take a healthy cell and make it malignant. Okay? Those are other processes that cause that. We all start with healthy breast cells, and then we actually get cancer every day. Y'all realize this?
Yes.
No.
We get cancer somewhere in our body probably every day, and our immune system immediately recognizes that cell is foreign and kills it. Okay? What happens when we get cancer is you've lost the ability to attack that cancer cell, or you have a tumor promoting cell, which promotes the malignant transformation of a healthy cell. So women who are diagnosed with breast cancer on HRT have lower stage and higher survival rates than women not on HRT.
The stat that really got me was that the number one killer of women is heart disease.
Cardiovascular disease.
Right? It's going to kill far more women than almost everything else combined.
Yes.
Right?
Yeah.
So we're all kind of afraid of hormones because the thought was it's going to give us breast cancer, but which it doesn't. And even if you get breast cancer, you still are more likely to die of heart disease than of your breast cancer.
One of the biggest risk factors for breast cancer is alcohol consumption. So if you're really serious about decreasing your risk of breast cancer, stop drinking alcohol. Family history, HRT has never been shown to increase the risk. Now, if you're a BRCA carrier, that's a whole different discussion. If you have a genetic, thing, and they're recommending, if someone's not recommending having your ovaries out with whatever gene you have, yet they won't give you HRT. I'm like, they let you hang on to your much higher estrogen in your natural reproductive cycles, yet they're going to take it away in your postmenopausal years. Just think about it. It doesn't make sense.
On the cruise, you gave a talk about what you would tell your 35-year-old self. I would really love, because it was a moving conversation. I would love you to kind of talk to us about that a little bit.
So it's one of the conversations I try to have with my kids. And it's, now that I know what I know, after all of this research and writing a book and, what would I go back and do differently? What would I tell 35-year-old Mary Claire? And I would say, number one, nutrition over calories. I was a cardio queen. I literally moved my body and ate to be thin. I equated thinness with health. I thought nothing of the quality of my food. And in medical school, we didn't learn, my undergrad's geology, so that was zero help, I mean, I'm a good scientist, but knowing that kind of stuff has totally changed my approach. So nutrition is more important than calories, and strong over skinny. I only exercised to be thin. I ran marathons to be thin and hang out with my girlfriends. And, why weren't we in the gym lifting weights? I didn't understand how important retaining muscle mass or building muscle is with age, and how that's going to determine the course of whether or not we get diabetes, whether or not we end up in a nursing home, whether or not we can get off a toilet without a bar on the side. All of that was so important. And we reach our natural muscle mass, without age starting to chip away at it at 30. And so, I wasn't eating adequate protein. I wasn't doing the resistance training. I was only doing cardio, really. And so that I would totally do that differently again. I would have learned about menopause, educated myself about the importance of menopause, what it really means outside of just hot flashes and your period stopping and not being able to have a baby. It is 1,000 times more than that. And I would have looked at aging as a privilege. I hated aging. I hated menopause. Old people, and now I'm an old person. And so I'm like, wait a minute, I'm living my best life right now. I'm more successful. I touch more people. I've changed more lives than I ever did doing pap smears, which I loved my job. But I was a terrible menopause provider at 35. I didn't know what I didn't know, and now I'm spending the rest of my life trying to make up for that.
We're so lucky to have you and everyone out now.
What a great conversation.
Yes.
Thank you so much.
Thank you for
Thanks
taking
for
the time.
having me.
I think it's really important to let everyone know that the book is launching on April 30th. Not sure exactly when this is going to come out, but April 30th. Also, I have to say, I have to plug it because you still didn't. Her collagen, skin and bone, is absolutely incredible. It's staple every day. I got my DEXA scan. And I was like, okay, I'm getting serious about lifting heavy and collagen. And so I'm going to list and link everything down below, everywhere you can find the menopause in general. I'm going to list them all. And awesome.
You're never going to say that word without me giggling a little bit on the inside. I love it.
We call it the
It's
metaverse.
so good.
We live in the metaverse now, and
I love it.
our menopause. So we're trying to come up with a clinical consortium name, and nothing is better than menopause, but it's just not going to fly. And so if anybody out there, we have this, the menopause is trying to find an official name.
Oh,
so that we can
Or you're gonna get flooded now.
we're gonna go and testify in front of Congress, about the FDA,
Oh.
and menopause really isn't.
Yeah, it's not going to cut it.
And up next,
the menopause.
Yeah.
you lock arms, you're all in your superhero kits.
Your capes are flowing.
I see that, actually. I
with the
endorse that.
MP.
I can see the vision.
All right.
Okay,
These in.
is this a wrap?
All right.
I think this is a wrap.
So.
Thank you.
All right.
All right, you guys, I hope you enjoyed that roundtable discussion. Please do leave any further questions down below. I am going to keep this conversation rolling. We have more guests to come. I have so much more planned for the rest of the year when it comes to wellness and kind of midlife menopause discussion. I'm really, really excited about it. I really appreciate you being here, and I will talk to you in my next skincare video. Take care.